Okay, good evening, good night, good morning, depending on what part of the world you are. Thank you for joining us. I was looking at the list and I've noticed that there was 600 plus people connected to our webinar today. My name is Mario Romero and I am going to be sharing with you this very interesting topic about the bonded functional aesthetic prototype and its clinical applications. At the end of our presentation, we will have a small segment for answering some questions. And I do want to take some time to say thank you to Cable Kerr, who is the company that has been able to sponsor this course and make this possible, definitely available for everybody that's watching us today. All right, so let's go ahead and get started. Let's go to the first slide. And little by little, I'm going to try to take you into what this topic is all about. And the first thing I want to share with you, the first word I would like to share with you is one related to communication. You know, let's think about this together. When you have large cases, when you have interesting aesthetic cases, you know, what are you using today to communicate with your patient? What kind of results you're going to achieve? And you know, many of us are you know, you can either do a mock-up and you can kind of have your patient seated on a dental chair, give them a mirror, take some photos, and kind of show them what you should be expecting as a result. But one thing that we're not able to do with a mock-up, that you know, you will be able to communicate, but one thing that you will not be able to do is to actually integrate your patient into the decision-making process of such important restorations. Your patient will be able to evaluate them seated in your chair. You know, they will be able to kind of have some phonetics with you, have a conversation with you. But right before they leave your office, you got to remove the mock-up and you send your patient back home just how they got to your office. So there's no way that the patient can communicate with anybody in their house, with their significant other, with their children, with their parents. You know, what is it that you're planning to achieve, or what would be kind of like the end result? And that's really what this topic is all about. You know, the bonded functional aesthetic prototype is going to take you to that next level. It's going to take you to that level where you're going to be able to not only kind of give your patient an idea of what you want to achieve, or what your end goal would be, but most importantly, your patient will be able to take this prototype because it's bonded to their teeth. They will be able to take it home, use it for a couple of weeks, kind of function around the prototype, have other people in their environment, and you know, friends, family, or relatives, just to kind of give them some input and let them know, you know, does it seem aesthetically pleasing to their eyes? So now you are involving them in that. You're not underestimating their decision making. You're actually involving them in that decision. That's an important decision of, you know, this is what we're looking for to achieve. Do you like what I'm planning for you? Do you like, you know, the shape of your teeth? Do you like the textures that we've created? Do you like the incisal embrasures? I mean, do you like everything that I've been able to kind of work through your system and now put it in your mouth and send you home with it, so that you're able to function with it as well? So this is kind of like the idea behind the functional aesthetic prototype. Now, is this something new in dentistry? And the answer to that question is no. Even though Dr. McLaren was the one that gave it, you know, that actually brought it out to the literature with this new name, bonded functional aesthetic prototype, it really was Dr. Buddy Mopper that actually introduced this into dentistry many years ago. And the idea was that he had to develop a technique in order for him to use or to fabricate temporaries for porcelain veneer preparations. As we all know, the clinicians that are out there, we all know that fabricating temporaries for veneer preparations is very difficult, because there's really little tooth structure removed, and we're going to need to, we can't bond them permanently because we're going to need to remove them anyway. And if we use a regular temporary cement, most likely the restorations will debond easily. So Dr. Mopper came up with an idea, with a very clever idea of, you know, spot etching and bonding resin composite on anterior teeth, and able to use these composites as a temporary restoration. But one thing that you know, one of the differences between that technique and what Dr. McLaren actually offered us today is that technique, you have to build every tooth individually. So it was very time consuming, and obviously that would add, you know, time and cost to the patient. So you know, how can we make this easier? And that's what I'm going to try to share with you. How can we make this, how can we simplify this technique, make it easier, and still serve the purpose that it was meant to serve from the beginning. So the other aspect of it is that now we not only have these veneers, this type of technique just to develop some temporaries for porcelain veneers, but we can also measure their functionality. And to be honest with you, I'll show you one case at the end where I use these type of prototypes in order for me to actually develop crowns, not only veneers, but wrap the whole tooth around with flowable composite and send my patient home so that I can really evaluate any occlusal issues that they may have, or I can really evaluate the new incisal position or the new occlusal scheme that I've developed for patients that have excessive wear or that need any type of vertical dimension, occlusal vertical dimension increase. So again, this is not only for veneers. This is what I'm going to show you at the beginning, but you will see at the end, towards the end, that we've added a couple of other functions to this same type of prototype, following the same guidelines that Dr. McGladden added to the literature a couple of years ago. So let me go to the next slide here. And again, one of the most important things that we have to do is understand our material selection. I personally like to use for the cases that I want to restore temporarily, that I want to use it as a prototype only, just for a couple of weeks. I rather use flowable composite, and the reason for this is because it's a lot easier to apply. It's quicker. You can do multiple teeth at the same time, and it's predictable. But I use this technique as well when I want to restore mandibular incisors for patients that I need to alter the occlusal plane, or patients that are going to end up using some type of removable prosthesis in the contralateral arch. So if I need some mandibular teeth that need some type of light occlusion, I will restore using exactly the same technique. And I'll show you one case that I worked on with one of our students at the dental school. But I use exactly the same technique to restore, to fabricate permanent restorations using composite on worn down incisor teeth. But definitely my number one choice for the actual prototype is going to be a flowable composite. Now, what kind of flowable composites are we going to use? Can we use any type of flowable composite? And the answer to that question is no. You need to consider the amount of fillers that your flowable composite has. And up to my knowledge, there's really, these are the two that I know. There may be more out there that are very highly filled, but the ones that I know are either Herculite Ultra Flow from Cable Kerr or Reveal from Bisco. These two systems, these two type of flowable composites are highly filled. I would say they're filled more than 80%. So that makes them more resistant compared to other type of flowable composites. And you want that because, again, you're going to use these, you're going to use this prototype, for a week, for 2 weeks, and sometimes when you use them, like I said, to alter the vertical dimensions, I have had these on my patients up to 8 months. So it really depends. You really want to make sure that you have a heavily filled flowable composite so that you can now try to maintain them, try to use these restorations for a long period of time on your patients without having to repair them frequently. So that's very, very important. And just to show you a quick photo, this is one case that I developed, that I actually did on a live continuing education course. So this was a live patient demo. So what you're seeing before and after, that after photo was taken literally 10 to 15 minutes after the procedure was done. And one of the nice things, as you can see, you may ask yourself, how come the patient is smiling so naturally and her lips have not been affected by any anesthetic? Well, the reason for that is because I normally don't numb my patients to do these type of procedures. And you can see the before and after photo. You can see how nicely and how well developed and pleasant these composite veneers are at this point. And this is my prototype fabricated with the flowable composite, following the steps that I'm almost ready to present to you. But most importantly, I want you to look at how nicely polished they are. Look at the gingival health that you may see. Even though all these restorations are bonded one right next to the other, we after we bond them, we use a diamond burr. We kind of open the gingival embrasure to give our patients some room for them to go back and clean while they're using the prototype. And if you ask yourself, how motivated you think your patient is going to feel immediately after you deliver these prototypes, and you send them home with the prototypes. So they're now able to function with them. They're able to have a, you know, have a normal conversation. They're able to show them to other people around them, to help them evaluate if this is what they're looking for. And at the same time, one more thing that these prototypes are good for is that once I'm ready to do my porcelain veneers or any type of restoration that we're going to fabricate for a patient, in this particular case, the indication for this patient is going to be porcelain veneers. You know, you're going to use these prototypes as your preparation guide. You're going to prep through them, and then you're going to analyze and you're going to calibrate how much tooth structure, if at all, needs to be removed. And again, I'll share with you a full case so that will be easier for you to understand. So again, can I use any other type of composite besides flowable composites? And the answer to that question is yes. You may use sculptable composites. You may use something like Harmonize. You may use something like Brilliant Everglow from Colteen. You may use any type of regular sculptable microhybrid or nanohybrid composite that you use in your practice. The only thing that you would have to do for these composites in order for you to be able to deliver them into the clear matrix and triad tray that we have to fabricate, you would have to warm up the composites. So I personally have a warmer, a composite warmer in my practice made by Adent, and what I do is I just insert my compules into the warmer. The warmer brings up the temperature within the compule all the way up to 151 Fahrenheit, making the composite, you know, very flowable. So even though it's a sculptable composite, it is easy for you to inject within the clear PVS and then sculpt in the clear PVS before you sit down directly into the patient's mouth. I'm going to show you a case using sculptable composites. I'm not going to show you the whole technique because again, I use more flowable composites than sculptable composites for this technique, but this is an option, and I'll show you a case so that you can evaluate it and say, you know, see if this is something that may fit your practice. But this is one really good option. And here's the case. You see, this is a case that I worked on with one of my undergraduate students at the Dental College of Georgia. I cover sometimes there the clinic for restorative and aesthetic dentistry, and you may see, you know, you can see what we did for this patient. This patient was going to have multiple extractions on the maxillary arch, and she was going to end with a complete denture on the maxillary arch. But in order for us to, you know, to stabilize the occlusion and to be able to fabricate a very nice removable partial denture for the mandibular arch, we needed to kind of redo that occlusal plane that, as you can see on the left side of the photo, you can see right here. And let me show my cursor right here. You can see this side. You can see the amount of wear and the cupping of the incisal edges all the way down to the canine and bicuspids. So what we did is that, you know, we did the whole 9 yards. We go ahead, we make the cast. We actually, you know, use a 20-degree template, and we decide where that new incisal edge position is going to be located. Once we know that, we add wax to the cast, and we localize the incisal edge in its new position using that 20-degree template. Once we do that, then we fabricate the clear tray and the clear PVS, and again, I'm going to walk you through the whole process of how to do that. But just using the same technique that I'm going to show you now, we add that the sculptable composite that has been preheated. Always remember, you got to preheat it in order for you to be able to inject it inside the clear PVS, seat it down on the patient's mouth. And this obviously was the first time that this student ever did something like this. So what we did is that we did one side first. We did the canine and both lateral and central on the right side of the patient, and then we did the other side second. So we divided the mouth in two different quadrants, the mandibular arch. Now, when you become very proficient with this technique, you can do all anterior teeth at the same time in one sitting, like I will show you how to do it with the flowable composite. So again, a very easy technique. You know, the sensitivity of the technique has a lot more to do with the actual preparation of all the guides and everything. That's what I'm going to show you soon. But the actual clinical technique, the clinical protocol is very simple, and I will show you a real live video recorded in the school with one of my residents, with one of our students, I'm sorry, working on a patient, and you will see how he was able to develop two prototypes for 8 and 9 prior to prepping these teeth for porcelain veneers. So let's go right into the laboratory aspect, you know, the technique, the laboratory and the clinical aspect of the bonded functional aesthetic prototype. And we're actually going to start first with the lab procedures. You know, what do you need to do outside the patient's mouth so that you can prepare to then have the patient come back to your practice and develop and deliver the prototype in the dental chair. So the first thing that you have to do is that you obviously you have to have a patient, and this is the preoperative photo of the case that I'm going to share with you today, and I'm going to go through the whole process, through the whole 9 yards of this case, all the way down to the final restorations, the final bonding of the veneer restoration that we're going to do 7 through 10 for this particular case. Now, I want to kind of walk you through the treatment planning of the case, you know, the way that I do it when I'm looking at my photos. And you can see here 6 and 11 are bulky canines. So the facial aspect or the facial contours of both 6 and 11 are more facial in regards to 7, 8, 9, and 10. So what, you know, by that being said, if you think about it, I am able to add a layer of wax on top of 7, 8, 9, and 10 without having to do anything to the canines, because the facial aspect of these canines are you know, they're slightly bulkier than the rest of the teeth. I'm able to add a little bit of volume to all other teeth from 7 to 10 and make them align, you know, maintain that alignment, that facial alignment that all these teeth should have in the regular arch. And I'll show you exactly the way it was done. So first, you got to develop the wax up, and this is exactly the same case. I want you to look at the canine number 6 and number 11, and I want you to see the amount of wax that I've been able to add to 7, 8, 9, and 10. If you look at this photo and you're kind of picky on the photo, you can see that right in this area of number 8, there's a little bit of stone showing through my wax. What that is because I don't prep anything underneath the wax. I'm only this is a definitely additive case. All I need to do is add wax. But there will be some areas where you need to add more wax and other areas where you're going to need to add less wax, and that really is determined by the position of the tooth. So if we think about this together, if I were to prep this tooth right now for a porcelain veneer, where do you think I'm going to need more preparation compared to the areas that I'm going to need less preparation? And I'm actually pointing at them. This area right here is going to be an area where I'm going to need more preparation because there's more tooth structure here and there's less wax, compared to the gingival aspect of these teeth, because here there's more wax and less, you can hardly see the stone underneath the wax. You can't even see the stone underneath the wax in the gingival aspect. And the same thing happens 7 through 10 all around these teeth. So right now I can say with high confidence that the amount of tooth structure that I need to prepare for this case is minimal. And that's another purpose of the actual bonded aesthetic prototype, that it gives you, it helps you as a guide. So once you have your wax up, the next thing that you got to do is that you have to create a spacer. And the way that you create the spacer, the way that I create the spacer, is I use putty matrix. This is Reprosil here that I'm using, and I just, you know, mix the base and the catalyst. I mix them together, and then I put them on top of a table and I tap on top of them. And the reason why I do that is because I want to make sure, just like you're seeing in the middle photo right here, I want to make sure that this putty matrix is not more than 2 millimeters thick. It has to be a very thin layer of this putty matrix, and the only way you can make it thin is by tapping it on top of a table or putting a glass swab on top of it and just kind of putting a little bit of pressure so that it thins out. I normally do it with my hands just because I don't want it to kind of stick to anything. I want it to be easy for me to pick it up. So once I have it there, I just use a spatula. I pick it up out of the table, and I use with my fingers very gently, and I wrap it around, as you're seeing here, I wrap it around the facial, incisal, and lingual aspect of my wax up. And I try to extend this spacer, you know, a little bit more distal. So I'm going to extend it at least at the canines or the premolars. You know, you have to involve some teeth that you haven't prepped, and you'll understand later why. So you want to extend it a little bit further back of the area that you're going to be working on. You can see this from the side. It's very thin. It's approximately 2 to 3 millimeters thick, no more than that. And that's what you want to be. And it's the same all around. So facial, incisal, and lingual. The other thing that I want you to visualize, it is very nice and smooth. So I take my time before this putty matrix polymerizes. I take my time to smooth it out very nicely with my fingers. And this is crucial because the next step is going to be, and here you can see how nice and smooth once it's polymerized. You can see how thin it is on the facial, how thin it is on the lingual, and how thin it is on the incisal. You can actually see a little bit of light going through in the incisal edge. So it's probably a millimeter in this area. Again, you want it to be thin because this is to calibrate the thickness of your tray and the amount of, and the distance between the tray and the actual wax up. You don't want this distance to be greater than 2 millimeters or 3 millimeters because you want to make sure that the light, your curing light, is going to go through, the light has to go through the clear PVS, through the clear triad, and onto the flowable composite so that the composite can start curing. So this is the reason why you're creating this spacer right here. Once you have the spacer, once your spacer is complete, the next step is to create the clear triad tray. And this is using clear triad. You can, this is from Dentsply. And what I do is I section a piece of the triad, and again, I want to treat it very nicely, very gently. I use some of the glycerin on my fingers, and I just kind of smooth it all around the putty matrix. So I'm going to put clear triad on top of the putty matrix. I'm going to smooth it all around, and I'm going to do the same thing, facial, incisal, lingual, very nice and smooth. And initially, I'm going to cure it with a handheld unit. Why do I do that? Because underneath the clear PVS, you have the wax. And if you put it in the triad oven, that's going to get very hot, and you're going to melt your wax. And you don't want that to happen, just in case you need to redo anything. So initially, I cure it with a handheld curing light. And then after it's partly polymerized, I remove the PVS, the Reprosil material, and the clear triad at the same time. I remove them together, and I put them into the triad oven for 5 to 6 minutes, leaving the cast outside the oven. So I'm only polymerizing the clear triad, and I include in that oven the putty matrix just to kind of maintain the body or the shape that I want on my clear triad so it doesn't shrink excessively. So once that is cured, you remove it out of the oven, and then you're ready for the next step. Another second option, if you want to avoid obviously going through the whole process of the putty matrix and the clear PVS, is using these clear trays. Clinician's Choice actually makes these clear trays, and obviously they sell them. You can buy them as well on Amazon, and there's a lot of companies that sell them on Amazon. They're very inexpensive, and that you have all shapes. You really are going to probably use the one that you're going to use the most is going to be the lower arch, because again, you want to try to be closer to the lingual aspect just in case you're doing a full coverage prototype. You want to make sure that you can light cure through the lingual. So I normally use the lower arch tray for the upper and the lower. Now, one thing that you got to keep in mind, and one of the downsides to using these trays, is that you don't have a calibrated thickness of your material. So you normally will end up, if you're going to do only veneers, it doesn't matter, because you can always push the tray a little bit more distal and get the tray to be closer to your wax up of the facial. But when you're going to do full coverage restorations, you have to have that 2 millimeter thickness all around, and there's going to be some areas with this tray where you're going to have a thicker material. So keep that in mind, and don't throw out of the window the previous technique, the one that I'm going to share with you, which is the one that I use commonly and that I use the most. I only use these clear trays when veneers, literally. The other thing that you have to do is that once you got once the clear triad is fabricated, now you're not going to use the putty matrix at all. So you can just disregard the putty matrix. All you're going to use from now on is that clear triad tray. And again, that clear triad tray, since it was cured on top of this very nicely and smooth surface of the putty matrix, there's no retentive features within that clear PVS, that clear triad, I'm sorry. You don't need to use any type of adhesive. All you're going to do is now choose a clear PVS impression material. And there's two that I know of in the market, and I use both of them in my practice. And this can be either Memosil from Harris Culture or Veal from Bisco. They both do exactly the same thing. They're both great products. So they flow very nicely, so they copy all the details that you have on your wax up. So whichever you decide to use, that's good with me. And here's my clear triad. This is right now the one that I have used is Reveal. This is the one that you're seeing inside my clear triad. And what I did is I literally injected the clear PVS into the clear triad, and then I with my hands I sat the clear PVS, the clear triad with the clear PVS inside onto the wax up. I made an impression of my wax up. When you're doing that, you got to kind of eyeball it and make sure that you're kind of centered, so that you have approximately 2 millimeters thickness in the facial, 2 millimeters in the lingual, and 1 to 2 millimeters in the incisal edge. So you kind of eyeball it, but you hold it in place, because this material is kind of, it flows, it runs easily. So if you let go of the triad tray, the triad tray will sink and will touch your wax up, and you don't want that to happen. So just keep it in place. Just hold it with your hand until it polymerizes. And it just takes a couple of minutes for the clear PVS to polymerize. But once you're done, and again, this is the same case that I've been working on from the beginning. There's my wax up. There is the polymerized or set clear PVS. And here's my clear triad right outside, serving as a shell on top of my clear PVS. So once you have that, then you're ready. You're done with the lab portion of this. Now you're ready for the clinical aspect. Now you're ready to actually do this in your patient's mouth. And that's what we're going to review now in the following steps. So I'm going to show you the case that I did live, the one that I showed you at the beginning, and you can see now this is the patient. I've retracted the lips. I just air dry everything, and the first thing that we're going to do is that we're going to spot etch. And how much do you spot etch? Well, the answer to this question is very easy. If you plan to keep your prototype for more than a month, a month or 6 months, I normally, if it's only a facial one, I'm going to acid etch my entire facial aspect. I'm just going to be 1 millimeter short of the gingival margin and 1 millimeter short of the incisal edge. So those are the only two areas I don't etch. I etch everything around that area. And I want to use a thick etchant. This etchant right here that you're seeing on the photo is made by Colteen. You can see it's very nice and thick, so it stays right where I apply. I don't want the etchant to be running, to be all over the place. So in this particular case, we're going to use our prototypes only for 15 days. So if I were to use it for 15 days, I'm going to just spot etch, just like you see here, approximately 2 millimeters in diameter. But if you're going to use them for a longer period of time, you need to incorporate more of that enamel into your etching procedure. Okay? So now you can see I have my etching pattern right in the center of the tooth. So my next step is going to be to apply the adhesive. And at this point, you're not only going to apply the adhesive on the edge, on your spot edge, you're going to apply the adhesive on the entire surface of the enamel. Why? Because you want to make sure that your prototype doesn't stain. You don't want it to flick off or fracture in the gingival aspect. You want to make sure that even though it's only etched, and that's what's been the bonded prototype in place, you still have some bonding of this composite to the actual enamel through this adhesive without any etching. But you're going to have some bonding, some sealing of your prototype, and that way you're going to avoid, again, small fractures or even staining of the margins, just in case you were to, the patient couldn't come back in a couple of weeks and you're going to have to wait a little bit longer. So you don't want it to stain, you want it to maintain, shininess and high luster surface. Once you do that, once the mouth is ready, once you've etched and placed the adhesive and you eliminate the excess and you light cure the adhesive onto the enamel, then you're going to grab your flowable composite and you're going to hold like you're seeing on this photo. So outside is my clear triad. This is the clear PVS, and this is my flowable composite being injected on the facial aspect of every tooth from canine to canine. Again, outside clear triad, in the middle the clear PVS, and my flowable composite is going to be injected on the facial aspect of every tooth from canine to canine. The reason why you want to have the clear triad at this point is because you can see that I'm holding it with my fingers. I want to make sure that I'm not putting any pressure. I'm not modifying the shape of my clear PVS. Most importantly, when I have this in the patient's mouth, so that you don't alter, the flowable composite maintains its consistency or its thickness all around the patient's mouth, based out of the wax up, out of the impression that you made out of your wax up. So everything is going to be determined by that wax up. So you can see here the clear triad is on the outside. The clear PVS is on the inside. I've injected flowable composite on the integral surface of the clear PVS, and you have to make sure that you fill that layer from the gingival all the way down to the incisal, approximately 1 to 1.5 millimeters thick. You want to add a little bit to the interproximal areas because, again, you want to make all these connect together so that they're, you don't spend a whole bunch of time, polishing the interproximal with some type of interproximal strips or anything like that. So you can see I have everything is inside. Everything has, the flowable composite has spread and wet the entire surface of the enamel. I'm sure I'm having a little bit of excess, but you'll see how small the excess is because of the way that this material, this impression material, copies with so much detail your wax up and the cast. It's just very thin layer of excess that you're going to have on top. Once it's fully seated, you keep it in place, and now you're going to start light curing through the clear triad and the clear PVS onto the flowable composite. So you don't remove the clear triad, you leave everything in place, and you start curing every single tooth for 20 seconds from the facial aspect. Once you're done with that 20 seconds per tooth, then you're going to remove the clear triad. And that's what I'm doing right here. So this is the reason why you got to make sure that they're both they detach very easily, that the clear triad has no retentive features with, inside of it, in the integral surface, so that the clear PVS doesn't move anywhere. Why? Because your flowable composite, though polymerization has been initiated, they're not completely polymerized. So if you were to remove the clear triad and the clear PVS at the same time, you will deform your flowable composite. So you want to make sure that you remove the clear triad, you leave the clear PVS inside, and then you light cure one more time, 20 seconds per tooth, only on the facial aspect. In this particular case, because these are veneer, these are composite veneer prototypes. Now, the third step is going to be removing the clear PVS. So now you remove the clear PVS. These flowable composites have received at this point 40 seconds of light, through a couple of millimeters of this clear triad and clear PVS, but now they're not going to go anywhere. They're solid. And now what you're going to do is that you're going to remove the clear PVS, and one more time you're going to cure directly on top of the flowable composite. What do you end up having? This is what you end up having. Now this photo was taken immediately after I completed polymerization of the flowable composite. I haven't used any type of burrs. I haven't removed any of the flash. You can see that I have a lot of, I have some flash in between each prototype, but you can see as well how thin it is. It is so thin that you can see the redness or the pink of the tissue, underneath this composite resin, flowable composite that has been polymerized beyond the gingival margin of each tooth. And yeah, you may get a little bubble here and there. They're very easy to repair. You can see how small they are, so they're very, very easy to repair. So once I'm done with this and once I'm done curing, the next step is going to be finishing. So you can see the type of burr, a very fine, red stripe or yellow stripe, fine diamond burr, very small kind of needle shape diamond burr. And you're going to use that needle shaped diamond burr, and you're going to go just into the gingival margins, right around the tooth, just to remove all the flash. And what I do is I just kind of barely cut a little bit into it, and then with the tip of the burr, just like you're seeing right here, without having the burr spinning, I just kind of, very easy to remove. It just tears easily apart. And then what I do is I use the tip of the burr again, and I go back in, and I make sure that I open the embrasure slightly. I just want to make sure that the patient is able to get a soft pick, which is a very tiny interproximal toothbrush, and it's actually made out of, the tip is made out of rubber, very soft rubber, and it's very, very thin. So all I want is for that soft pick to go in between the embrasure area. So I leave a fairly thick connector, but they will be able to clean in between each tooth using those little soft picks. If I were to do this on posterior teeth, then on posterior teeth I do open my embrasures a lot more, and I make sure that the patient can get just a regular interproximal toothbrush back there when I'm doing full mouth cases and I'm doing prototypes all over the patient's mouth. Once you do that, you can grab any polishing system that you like. Right here I'm using Softflex from 3M, and you can go in and just kind of go right around the margins. Again, the patient is not numb. All this is done without no anesthetic being infiltrated on this patient. And I just go around and just kind of smooth out all the margins, make sure that all the flash is out, and make sure that it's like a knife edge margin between that unprepped enamel and my margins of flowable composite. And I make sure that I do that all around every single tooth. And I, at the end, just grab an explorer, a very thin, sharp explorer, and I make sure that there's no retentive features in that gingival margin. I want to make sure that there's no gingival inflammation throughout the whole time that the patient is using the prototype. And then after that, I just polish it, and there's many things that you can use to polish it. I only use the Softflex system, the medium course, just to kind of go around the margins and get very nice and smooth margins. You can see this is tooth structure. There's a little bit, you can see the line of the flowable composite, almost invisible, almost imperceptible. But you can see that this is the actual tooth of my tooth structure of the patient. So this tissue is never going to get inflamed. Same thing over here. but at the same time, you can see the contours, the line angles, the emergence profile, and then you can go, I sometimes use enhanced points, or I use these polishing wheels. Colteen makes very nice polishing wheels that you can use, and these are the ones that I'm using right here. And you can just go in and just highly polish. This creates a super highly polished surface, and you'll see at the end how nice. Look at the way the line shines around the line angles and how smooth the entire surface is. Now this is a single shade. This is a monochromatic flowable composite, so I use probably A1 or B1 for this case, and those are the shades that I normally use. But you can see that since the flowable composite has different thicknesses from the gingival all the way down to the incisal, you can see a little bit of translucency effect created even throughout this single shade composite on the incisal third. So again, you end up with a very, very nice restoration, prototype type of restoration that this is bonded. This is not going to go anywhere. Patient is ready to go home and just start. Now I'm checking just the occlusion, make sure that there's disocclusion of all posterior teeth, that there's no interferences in protrusive movements, and this is a frontal view, and you can see the same thing on a side view. We're going canine guidance, and just to make sure that all the occlusion is there so that there's no chipping or fracturing of our prototypes. They can fracture something. I'll show you one case where one fracture, they're very easy to repair, and normally when they fracture on me is because I overlooked a little spot, a little area of my of when I was doing the occlusal adjustment, and I'll show you a case exactly where I did that. And look at the immediate smile. You can see this is immediately after. There's no anesthetic, so the patient can smile. The patient can have a nice conversation with you. You can take all the photos you want and then share these photos with your patient and with their family members. I share them with them, and I just take them home, just have other people look at the before and after, and tell me, give me your feedback. Tell me if you're happy with my plan, if you're happy with the way that I'm working around your case, if this is what you were looking for as a final result for your new smile. So I involve my patient with the decision making. So again, I'm going to now go back to that initial case that I showed you, the one that I created, the triad tray and the clear PVS just a couple of minutes back for you. I show you how to do it step by step, and I'm just going to walk you through this case from prototype all the way down to preparations and final delivery of 4 porcelain veneers, so that you can understand the whole process. We already viewed this photo, so I'm not going to go back and talk about that photo. But as you can see, I'm going to go to the previous one. Look at this. Look at the stains. Some areas of some staining and some unsupported enamel. All I did was remove a little bit of the staining and the unsupported enamel. So there's literally there's no preparation more than just eliminating that unsupported enamel and the stains, because I don't want the stains to show through my prototype. I want to enhance our smile. So you always, think about that always, and make sure that you do eliminate them if there's any before you do your prototype, because this is a very thin prototype and the composite will be a little bit translucent in the areas where it's going to be thinner. So once I'm ready and everything is ready for me to go, everything has been done in the lab, so I'm ready to do the clinical aspect. Again, I'm going to wear these prototypes for a couple of weeks, so I'm going to spot etch for 15 seconds. Try always choosing an etchant that has a lot of body to it so it doesn't flow everywhere. I rinse after 15 seconds of etching. I rinse, I bone dry, and then I apply my adhesive all around the surface of the enamel. Remember, not only on the area that you spot etched, everywhere, so that you don't get any staining of the margins, you don't get any, you get very well sealed restorations, temporary restorations, but they're very well sealed. Then I go back, I inject the flowable composite into the intaglio surface of my clear PVS. With the clear triad shell on the outside, I sit this directly into the patient's mouth. Now you can understand this is not going to, this clear triad is going to let me alter whatsoever the shape of this clear PVS. And then I start light curing through the clear triad, 20 seconds per tooth. Here's going to be 4 teeth. So that's the time that I'm going to spend, light curing. Then I remove the clear triad, leave the clear PVS, cure one more time, 20 seconds per tooth. Then I remove the clear PVS and go directly onto the flowable composite and cure one more time, 20 seconds per tooth. And this is immediately after removal of that clear PVS. And you can see that this is completely polymerized, and a little bit, look how thin the flash is. Very easy to identify, very easy to follow the gingival margins of these teeth. You can see that the canines were not incorporated in this prototype. All I'm doing is from lateral to lateral, from 7 to 10, and you can see that I followed the actual natural contours that the facial contours that the patient presented on her natural canines. So now we can understand what an additive technique means and why in this particular case there's not a whole bunch of preparation I'm going to need to do, and these prototypes are going to serve the main purpose when I get to the preparation, which is calibration of my preparations, and I'll show you that in a minute. Again, this is immediately after getting that little diamond burr around the gingival margins, getting to the embrasure areas. You can see I've created enough space for me to get one of those soft picks right in between the embrasure areas. Everything from 7 and connected together. They're not going to go anywhere. And now they're polished and the patient is ready to go. We make one, this is the occlusal exam right after the delivery of the prototype. And this is the contact that I was, I'm looking at the contact now in the photo, but I overlooked at this contact, this premature contact when I was actually delivering the prototype, and I did not remove it. And I'll show you what happened, a week later. But this is immediately after, and I want you to think about this. I show my patients right at that moment the before and after photo, how she got to my chair when I was making all the impressions and the photos, and then how she's leaving my chair today after I delivered that prototype. You can see this is a full smile of the patient. She's extremely happy. You can see that she hasn't been numb, but most importantly, she's already telling me how much she likes her new teeth and how much she likes my plan. And I'm taking all these photos, make sure the incisal edge position is correct, just making sure that she feels comfortable with my temporary bonded prototypes. Now, a week later, you can see this is the area where the connector was hitting when I had that hyperocclusion there, and you can see the fracture that happened because of that. Now, the prototype doesn't come out. It's just a little fracture. Everything is in place. It's not like she's going to, the temporary came off and now she's got these teeth, these spaces, half of her mouth. You can see that they're still bonded. So all I got to do when she comes into my office, she called me. I said, come to the office, and this will literally take me a couple of minutes. I use a number 1 or number 2 round burr, just kind of cut a little groove in between this fracture line, add a little bit of flowable composite, sit the clear PVS only, without the clear triad, cure through it, and boom, there you go. 20 seconds later, it's been repaired. I polish, I send the patient back home. Obviously, I adjust the occlusion. I always got to think about what is the reason behind the fracture. Just don't think that the material fractured because it wanted to fracture. Normally has a lot to do with occlusion. This was the case. So I went back, I adjusted the occlusion, sent the patient back home. When she returned for me to prep the teeth, no more fractures had happened. And you can see how nice and healthy the tissue was just a week later. And you can still see the spaces that I've created for her to use the soft picks. So now I'm going to go ahead and I'm going to show you a real life video. This is one of my students, Kevin Shepard, actually is his name, and he was the one. He had this patient. This is when he was a 3rd year dental student. He's a 4th year dental student now. But I want to show you the way that he delivered the prototype. Again, we did the impressions and the wax up all before the patient got into the clinical chair. You can see what we were trying to achieve. We were trying to bring these 8 and 9 a little more facial because of 7 and 10. And you can see the wear on the incisal edge, and we've bleached already the upper teeth. And now we're gonna go back to the lab. Patient goes home. We go to the lab, and Mr. Shepard went ahead and waxed up 8 and 9, and you can see how much wax he needed to add to kind of get these teeth aligned with 7 and 10. And again, you think about it, how much do you really have to prep? I mean, this is a real additive case. So now we are in the clinic with the patient and we're ready to deliver a prototype. So you saw spot edge. Now we're going to put some adhesive. Again, the only spot edge, but we're going to place adhesives on the entire surface. Now we are ready. We have the clear triad, the clear PVS within the clear triad. I'm going to inject the flowable composite to the intaglio surface of 8 and 9. And then I'm going to hand the prototype to Mr. Shepard, and he's go ahead and seat the clear PVS and the clear triad onto the patient's mouth. You see, there it is. There's the clear triad on the outside, clear PVS on the inside. This is the first time he's doing it, so he's kind of making sure that everything is okay. Once he knows he's got the right fit, he sits this completely you seat it one time, and now I'm going to hand him the curing unit. And there is the curing light there. He's going to place it right on top of number 8 through the clear, he's going to start with number 9, through the clear triad tray and through the clear PVS. And he's going to do the same for number 8. Now, I want you to see how he gently removes the clear triad. There's no retentive features within that clear triad and the clear PVS. So the clear PVS just stayed right in place. And that's what you just saw. He removed the clear triad. Everything stayed right in place. Now he's ready to cure through the clear triad. Once again, 20 seconds per tooth. 20 seconds number 8, 20 seconds number 9. And then we're going to now remove the clear PVS. And there you go. Remove the clear PVS. And you can see a little bit of the flash. And now he's going to cure directly onto the flowable composite. So you saw, same sequence, 3 curing times, 20 seconds per time. The last one directly onto flowable composite. And there you see a little bit of flash up here, a little bit of flash there and there. Very easy to remove. And you'll see on the video, again, I want you to keep in mind, this is the first time ever Mr. Shepard, third-year dental student, was doing this. So he's being very careful, and see the, the very thin diamond kind of needle type of diamond burr, and he's getting into the embrasure area. Patient is not numb, so he wants to be careful that he's not going to damage the tissue, or he's not going to, do anything that may make the patient uncomfortable. And then we check the margins with the Explorer. You can see that there's no catch on the margins. Everything is nice and smooth. So there's a very nice transition. If you find any catch, you go back with the soft flex disc or with the burr and just go back and repolish. Very, very easy. And now he's just getting that high luster. With these polishing wheels. Again, there's 2 or 3 of them, and we use them all. We get very, very high shine, depending on the system. There's some systems that have 2, others have 3. But you can see how nice and shiny this is. Very, very good result, I think, for a first timer and a third-year dental student. So now we're going to go into the preparation. So how can the bonded functional aesthetic prototype help me with my preparations? And again, you see, I'm going to use my depth cutting burrs directly through the prototype, and now I'm going to make all these lines come together. And you can see right here, the prototype is still in place. I've only removed the facial aspect, make all those 3 lines come together. You can look here, you can see here, there's a little bit of flowable composite here, but this is tooth structure. And now I'm going to remove the prototype completely, and look how much very little tooth structure removed in all 4 teeth. So all I got to do now is give a finish line, make sure I get it in approximately so that I can close all these embrasures and diastemas and give this patient very nice looking teeth. And that's what I just did. Very shallow margin, very, very thin margin. All my preparations are 100% enamel, which is the best tissue to bond any type of porcelain veneer on cases like this. All enamel, very nice, smooth, round line angles, ready for my impression. And this is the guide that I fabricated on top of my wax up, just to make sure that I'm calibrating my preparation, and I can tell that I'm giving the lab enough space, because again, he's got to add. There's not a lot. I don't need to remove a lot because he has a lot of room to add the porcelain. And there's my final impression. And now I have this other putty matrix that I use to fabricate my temporaries. In this particular, for my temporaries, I use exactly the same technique as if it was for the prototype. The only difference is that I use the Reprosil material, and then I use a light material to copy every single detail of my wax up. And then I inject, and I spot etch the tooth. I add a little bit of adhesive, this time only on the area that I spot etch, because I want to remove these temporaries easily. And then I use, this is integrity, I inject the integrity within the integral surface of that clear of this putty matrix. I seed it into the patient's mouth, remove any excess through these little notches that I cut right here, and then I just polish the margins, and these are my temporaries. And that's immediately after I made my impression. And this is the temporaries directly into the patient's mouth. They're all bonded together, one right next to the other, and they're bonded through a spot etch and a little bit of adhesive only on the spot etch area directly onto the tooth. So once I do this prototype, I never remove the temporary. I only polish it, and the patient goes home because it's already bonded to the area that I spot etch, and I add the adhesive directly onto the patient's tooth. So then the lab sends me back my veneers, and you can see how beautifully crafted these feldspathic porcelain veneers were, and how thin and they are, and how much light goes through them. So, you know, again, this is, you know, a lot of very, very meticulous work. Everything is step by step. This is the technique that the lab uses, my lab guy uses to do his porcelain veneers, his feldspathic porcelain veneers. And you can see he added some clear porcelain here. Then he adds, you know, different colors, different shades of porcelain right on top, creates all the halo effects and all the mamelons. And then he just, you know, uses some finishing stones to recreate all the texture on the surface of these teeth. And you can see how natural the texture and the stain glaze looks there. And then we're ready. We're ready to now isolate our patient, and now first make sure that these restorations fit in perfectly. And that's what you're seeing right here. I'm seating the restoration onto my preparations. My preparations, you can see the mark is visible, and there is one of the porcelain veneers seated. Very nice, you know, very nice fit. I'm ready to try in all the rest of the veneers. Once I try them all, I go ahead and I just, you know, use hydrofluoric acid for, this is feldspathic veneer, so I'm using it for 60 seconds. I rinse the intaglio surface. I apply my silane. So I go through the whole 9 yards of the adhesive stuff that I'm not going to walk you through right now. But you know these better than I do. And then I select the cement that I want to use to bond my restoration. I'm always going to use for this type of restoration a single bottle dental adhesive, because I want to have a very thin layer of adhesive. And then I choose a very, you know, a good system. In this particular case, I'm using NX3 light cure veneer cement. And this is, you know, one cement that I like a lot. That has a try-in paste. And what I like about the try-in paste is that you have only three options. You normally are going to use the clear option. This is the option that I use here. But, you know, you have sometimes you have one of these cases that you need to have a lighter shade. You need to kind of highlight a little bit the value of your veneer, and you maybe use a white cement. And what I like about the white cement on Nexus or NX3 compared to other brands is that it's not that frosty white, and not like the opaque white that when you have a thin veneer, you'll see that white through your veneer, that very intense white. This has more of a natural looking tooth color white that really blends in, and I personally like it a lot. And here you go, you have all my 4 porcelain veneers bonded to the surface of the teeth, and you can see all the intrinsic characteristics that the lab guy was able to, my lab tech was able to get into these veneers. Wonderful job by his wonderful crafted and gifted hands. And you can see here, these are the temporaries, and I'm just going to show you the before and after. And this is immediately after. This is actually not immediately after. This is 30 days after all 4 veneers were bonded. And I want to show you something. This is the canine. This is the patient's natural canine. And look at the gray and the white and the little fracture lines, and exactly the same things we were able to recreate. The lab tech was able to recreate. This is not me. This is the lab tech. You know, beautiful work, very nice, recreating all those minimal, those intrinsic features within teeth, and making these just look very, very nice and natural. And there's one more thing that I want to share with you in these last 6 minutes that I have for my presentation. Is just another application that we just recently published this clinical case, just to give another application to the bonded functional prototype. And I'm going to just kind of show you quickly how important this could be for full mouth rehabilitation, and most importantly, you know, for cases where you have to modify the vertical dimension. And as we all know, you know, one of the most difficult things to do is increase vertical dimension on our patients. Not because, you know, we know that there's a lot of evidence to support that we can modify vertical dimension 4 to 5 millimeters without having any issues, and there's a lot of literature supporting that. But one of the most important things that we want to make sure is that the patients comply with our treatment. The only other option that you may have to alter the vertical dimension on a patient as a trial period, in order for you to make sure that there's no clicking or popping or no pain or tenderness of the muscles and the TMJs, and make sure that everything works well, is either using a splint. And the downside to the splint is that, you know, it does its job, but the patient needs to wear it. And the problem is compliance. Patients don't like wearing it, and if they don't wear it, you don't get the information that you need. The only other option, the only very aggressive option that you may have, is prep all the teeth and fabricate your temporaries at that new vertical dimension. Well, at this point, the patient is already vested, and he's already into the treatment. So yeah, you may do that on a patient that knows exactly what he wants and you know exactly where you want to go, and there's really very little trial that you need to do. But in my hands, that just simply doesn't work. I just see dentistry a little bit different. So for me, I want to make sure that I feel more comfortable having a trial period with something that I can, that is retrievable, something that is can always remove and put my patient right at the beginning, exactly the way that she got to my practice. If for whatever reason she doesn't like the numbers and she doesn't like the complexity of the treatment, or he doesn't like the complexity of the treatment, and they just don't want to, go into that treatment at this point. And so there's a lot of research as well, as you can see here, supporting the use of these composites, regular sculptable composites. These are where the ones were tested, like Herculite XRV, for 2.5 years with 94% success rate when you're using these composites to restore, for an interim restorative procedure, for an interim restoration, not a permanent restoration, but a very long interim restoration. That's what I like about using composites. Now, flowable composites are not as strong as sculptable composites, but again, I'm only using these for 2 weeks, 3 weeks. In this particular case, I'm going to show you, I use it for 3 months, and that's all I need in order for me to make sure that I'm in the right spot. That this patient had some symptoms at the level of her temporal mandibular joint. She had some clicking and popping of the joints, and she had a little bit of tenderness of the muscles on one side. So I wanted to make sure that me modifying the vertical dimension was not going to make that worse. I wanted to make sure that it was going to make it better, if at all possible. So this is the preoperative view of the patient. You can see she was missing one of the mandibular incisors. She had a combination of natural teeth with a lot of PFM crowns, and that's what you're seeing right here. So this was challenging because we had to bond to these PFM crowns and to the natural tooth. So here I'm going to obviously remove a little bit of the glaze by etching these PFM crowns with hydrofluoric acid for 60 to 90 seconds, and then remove that, place my silane, put my adhesive, and then do the totally separate bonding procedure for my natural teeth. The ones that I have 1 and 2 natural teeth here, and I had 4 crowns. So I was gonna do the whole mouth, but I'm gonna split this in first. I'm gonna do the anterior guidance, and then I have my patients come back in a week, tell me how they feel there with no posterior occlusion, and then I go ahead and do my posterior teeth. So I'm gonna do the whole mouth, but I'm not gonna do it all at the same time. So I'm just gonna etch depending on the substrate that I have. And this is an occlusal view of how we were getting started on this case. And this is my wax up. So I send this particular case, I mounted the cast, I send it to the lab. I altered the vertical dimension 3 millimeters, and I fabricated an incisal guide so that the lab know exactly what I was looking for. They went ahead, they waxed the whole case up for me, and then I fabricate all, how I fabricate these already. I do all the trays and the clear prevest, and that's what I'm doing right now. I'm going from canine to canine on the maxillary arch, and from canine to canine on the mandibular arch. Again, these are very precise. There's very, very little occlusal adjustment that you're going to have to do on these prototypes in order for you to get all the teeth touching at the same time and with the same intensity. Now, this is immediately after I've completed all anterior teeth. And this is how I send my patient home. Why do I do this initially? Because if I don't have any posterior contact, and she had one side was very tender, now I know that I have many teeth, all these anterior teeth touching at the same time and with the same intensity, with no posterior teeth in contact. So I know I don't have any posterior interference that may cause those muscles to maintain that tenderness or that contraction that they have at this point. So in a couple of weeks, those muscles are going to relax because there's no posterior contact. So the elevator muscles are going to relax. They're going to contract, and the depressor muscles, the inferior lateral pterygoid, is going to relax. And by that happening, the condyles should go up the slope against the eminentii towards centrogulation. So my thought process is, this patient, when she comes into those 15 days, after the 15, she's wearing this anterior guidance prototype, she should be either pain-free or a lot better than she was before, and she should be able to communicate this with me, because she's not able to remove these prototypes. They're bonded to her teeth. So this is what I like about this particular vertical dimension or splint for vertical dimension ink, that this splint, if you call it that way, is bonded to the actual teeth of my patient, crowns and teeth in her case. So you can see no posterior contacts whatsoever. She only had anterior contacts, and that's how I sent her home for 15 days. 15 days passed by. She comes in. She was a lot better. No tenderness of the muscle. Completely relaxed inferior lateral pterygoid. No tenderness at palpation. She had no clicking and popping of the joints at this point, and she felt a lot, very, very comfortable. She felt, much more comfortable than when she was at the beginning. So now I know that I have my anterior guidance established. My incisal ledge position is correct. She's happy with the phonetics. She's happy with the aesthetics. Now I'm going to go ahead and do the rest of the occlusion. And you can see here, I do my prototypes on top of these crowns, on the occlusal surface of these mandibular crowns. Same thing down here on this 3-unit bridge that she had here. And then I do these porcelain crowns that she's got here on a natural tooth back here, and this natural tooth here and natural tooth here. So now I'm going to add the flowable composite to the posterior teeth and make sure that all the teeth now come into contact. There's maximum intercrispation at the same time that the condyles are fully seated, bone braced in their centric relation position. And this is immediately after all the rest of the prototypes were done. Look how much volume I was able to add to the smile. You can see a lot more teeth. A lot, this is more aesthetically pleasant. She's used to now the new incisal edge position. But you know what? The most important aspect of this case, and the thing that I want to show you here, is the panoramic X-ray. This panoramic X-ray that I'm showing you right here, the first one that I'm sharing with you, was taken before I did any prototypes. This was taken the day the patient sat in my chair for the first time, with all the symptoms that she was referring that she was having. If you look at the condyles, this is the left condyle, this is the right condyle. Look at the distance, look at the difference in the distance between the condyle and the glenoid fossa on the left side compared to the right side. And again, if we fabricate an orthopedic appliance, which is a splint, regardless of the material that you use or the technique that you use, the whole purpose of an orthopedic appliance is to help you stabilize not only the teeth, but most importantly, where the system starts or where the system works, which is actually up here in both glenoid fossas. It's up here in the TMJs. This is the area where all this system works. So you got to make sure that this is healthy before you do anything major in this occlusion. And I think that we'd all agree on that. But this is the panoramic X-ray taken 15 days later. So this is the day that I did all the prototypes. I'm sorry, this X-ray was taken 3 months later. So I did all the prototypes. I adjusted all the occlusion on the new prototypes now on the posterior. So all the teeth are now in contact. And now the patient, this is a 3-month follow-up X-ray, panoramic X-ray. Look at the condyle and the disc on this side. Look at the condyle and the disc on this side. A lot different than the X-ray I showed you before. So this prototype served its purpose, not only to improve the aesthetics and to guarantee and to show me the functionality of my plan, but most importantly, in this particular case, it served as an orthopedic appliance, making sure that I was able to stabilize the occlusion by stabilizing the starting point of dentistry, starting point of full mouth rehabilitation dentistry, which is the position of the condyle in the glenoid fossa. And if I'm not mistaken, that is my last slide. I'm going to go into some of the questions that we have now. Let me go here, and there's one here. And it says, can you bond cuspid which has been almost flat due to attrition? Yes, I just showed you right now this case where we actually, the last case that I just shared with you, we actually, the wax up really modified the incisal edge position and the canine cusp position as well. So everything was redone in that prototype. And yes, you can do that. You can use it in that regards. All you got to make sure is that when they're functioning on this new incisal edge or canine guidance position, everything distal to the canine disoccludes, so that you can shut down completely the elevator muscles while the mandible is off. It's moving, is in a protrusive lateral movements, so that you don't have any excess muscle or any overcontraction of muscle affecting or hitting your restorative work just recently done that is obviously going to make it fracture. So you got to make sure that you adjust the occlusion perfectly, and you will be able to use it anywhere in the patient's mouth. Again, don't forget as well that you are able to use regular composite and not only flowable composite. I'm going to do one more question here. Let me see if I have one more. It says, can you self-cure rather than light cure flowable composite? Well, there is no flowable composite that I know of that is highly filled that is self-cured. So if there's one out there in the market, yes, you can use it. I don't see why not. The only downside to self-curing that I can see is that you don't have any control on when the material starts polymerizing. You want to make sure that when you see this clear triad and clear PVS, the material is completely flowable and it's zero polymerization has occurred, so that it can fully seat and you can get exactly what you planned in your wax up. So that would be one downside of using a self-cured flowable composite. Again, I've never done that. I don't think I would recommend it, because I think it's going to create a little bit more issues than solve any problem. I want to thank everybody that was with us tonight. Thank for all the questions and the great comments, and I wish you the best, and hopefully we will find ourselves here one more time in a future webinar. Thank you very much.